Hello and welcome to a webinar on Sart for the rest of us. I am Sarah Ramaya, Curriculum Designer at ASRM. Please join me in welcoming my colleagues Jessica Goldstein and today's moderator, Dr. Bill Peacock. Dr. Peacock is a psychologist in independent practice in Baltimore with 35 years of experience in the mental health aspects of reproductive medicine. He is the past chair of MHPG and the Electronic Communications Committee of Sart. Before we begin, please note, this webinar was developed by the Society for Assisted Reproductive Technology and the American Society for Reproductive Medicine as an educational resource and service to its members and other reproductive professionals. While this webinar reflects the views of the panelists, it is not intended to be the only approved standard of practice or to dictate an exclusive course of treatment. Members should always use their best judgment in determining a course of action and be guided by the needs of the individual patient, available resources, and institutional or clinical practice limitations. All attendees will be muted except the presenters. Time at the end of the presentation will be reserved for questions. Please type a question in the question chat window at any time. We will read as many selected questions as possible to the presenters during the allotted question and answer time. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. I will now turn the presentation over to Dr. Peacock to introduce today's speakers.
Good evening if you're on the East Coast, and if you're anywhere else in the country, good afternoon. I'm Bill Peacock, and I'm very pleased to be hosting and moderating this seminar, Sart of Us, which grew out of a discussion about the knowledge that individuals who are members of ASRM have about what it is that Sart actually does. Very pleased to have three outstanding presenters tonight. The first presenter is Dr. Lin. He is a private practice board certified reproductive endocrinologist and infertility specialist and a founding partner at Seattle Reproductive Medicine. He's currently the Sart president and busy with a full-time clinical practice in the practice of ART and reproductive surgery. Dr. Lin.
Thank you, Bill, for that nice introduction. I appreciate the opportunity to discuss what Sart does overall, especially to those who don't know too much about Sart and its benefits as members, but also to those ASRM members who are non-Sart members thinking about being a member individually or as a clinic. I have no disclosures. So what is Sart? Sart is you. Sart is a very specific affiliate society within ASRM that is specific to the practice of ART, otherwise known as IVF. Its specific goal and agenda is to keep the profession of ART at the highest level of patient care. Patients are our primary goal. As Sart president, I've been very busy trying to herd the cats and keep the strategic plan and services of Sart moving forward. But in the end, I am you guys, just another busy REI clinician dealing with the same issues and challenges that you are dealing with in running a clinic, especially in these challenging times moving forward with COVID-19. In the end, 80% plus of ART clinics in the US are Sart members, so we're very influential. So this is just the tip of the iceberg. Sart does many things for its members. A lot of it is behind the scenes work, like branding. A new subcommittee under the Electronic Communication Committee is working hard to bring patients to your practice and associating your future patients that Sart means quality. And one of the main emphasis of this presentation is that quality practices are Sart members. The quality metric is not a bunch of fluff. Sart really does make its members go through some very annoying hoops. Most annoyingly, as police, our field is to make Sart members be the best they can be. If we don't do it, guess who will? Governmental regulations, rules coming from politicians whose agenda is to get reelected and not our own patients, and governmental bureaucracy that have little understanding of the nuances of our field. As a practice, you want folks like me and start working with you and understanding your practice, helping you be the best that you can be. I know all of you run good practices, but really great practices all acknowledge they could be better. And Sart has many resources for you to consolidate all the knowledge in one place for you to use. Some examples are like COVID-19 resources, the consents that we developed for ART, and advertising guidelines, to name a few. So driving patients to your practice is what the Sart branding campaign is. It's a social media campaign. It's direct to consumer. It's getting the word out to your prospective patients that when you choose a practice, you got to start with a Sart member, because they follow certain minimum high quality standards in the practice of ART. You can see here that you can get stickers to place in your entrance notifying patients that you are a Sart member, and Sart members are awesome. Sart membership also makes reporting your data easy. As many of you know, there is a Wyden Law of 1992, the Fertility Clinic Success Rate and Certification Act. All ART practices are required to report their outcomes. Sart Cores is the software that you may or may not know, but that each Sart member clinic uses to enter their patient data and outcomes, hopefully real time. Every medical director and data entry person in your practice, both lab and clinical, should be familiar with this page. Everybody starts with entering their patient information of who's going to do an ART cycle within your practice that you can see there pointed at the arrow. Every Sart member, and even non-Sart members, should have an identified person or persons whose job is to comply with the federal government law to report the outcomes of every single cycle. Sart members just have it a lot easier. Sart members have access to Sart Cores, which is the outcome reporting system. All your clinic staff who are familiar with reporting outcomes should see this page as being very familiar. In the upper right-hand corner, there are FAQs, there's a glossary, there's a question and answer formats where you can email our vendor and they can have answers and reporting their outcomes answered within 24 hours. There's also a data dictionary, which took many years to develop, to answer questions about each variable and how it's defined. At the bottom, there are portals and more portals. There's actually a separate webinar that directly addresses what these are. But in summary, there's a key member change portal, there's an advertising portal, there's a portal to see your members, your membership bills and cycle fees and how to pay. There's also a newly developed membership portal that is in development, so we can communicate better with our members about benefits and questions that they may have, rather than relying on unreliable email that goes to your junk mail folders never to be read. There's also a QA portal, and there's also a validation portal, all of which are very important in Sart's leadership in communicating with our Sart members. Sart members have a much easier way to enter data. With the Sart Cores platform, it takes on average about 8 to 10 minutes to enter data when you're really, really good at it. If you are a non-Sart member, the NAS, the National Assisted Reproductive Technology Surveillance System, takes a bit longer, about double the time. This is a huge cost savings from a practice standpoint, because you're not having staff members spend so much time entering the data, because some of us have thousands of cycles to report. And this can be actually very time consuming in entering data rather than the important patient care that they should be providing. Sart membership means quality. There's Sart advertising guidelines where Sart members are required to report their outcomes in an honest and fair and non-demeaning way. And yes, there's a wrist-slapping approach to it, but who else is going to do it? We do it in a very fair and objective fashion so that we don't have our Sart members fighting each other, keeping each other accountable. Also, Sart Cores has a self-monitoring system where members can report anonymously and securely advertising guidelines, and Sart takes care of all the interaction that can be quite uncomfortable. Also, registry committee oversees the quality of the data that is standardized so that the data going into Sart Cores is better and more accurate, and make sure that it's not a complex process where errors can be made clinically by your data entry people. Also, the quality of the outcomes is scrutinized to make sure there are no outliers, so that gaming the reporting outcome system cannot be done. The validation committee's specific job is to vet the data for outliers for very high live birth outcomes, low prospective reporting, high multiple rates, high fertility preservation cycle rates, etc. And even performs on-site validation visits to educate and confirm that the data that is being entered is really reflective of the clinical care and practice of their patients. In addition, the QA committee provides feedback to Sart members so that you can be as good as you can be, Report cards are annually distributed to Sart member clinics to know where they stand, and then they can choose to improve or be reassured that how they're practicing is providing best care. Sart membership also requires accreditation. This is an important part of a quality ART practice. All Sart member clinics and labs must be inspected and accredited routinely by CAP and the Joint Commission, both of which have guidelines and policies that are specific in making sure that embryology labs are as quality as they can be. ART clinics must present their data. Sart makes it easier. We all know that patients need to know what they're getting when they enter the physician-patient relationship. We all know that live birth is basically the most important outcome. We have all these QA metrics that we all look to be better practices, but the sentinel event that the patient really cares about the most is live birth. And we report them by retrieval, by transfer, by subsequent FET, and live birth per patient. We also have a snapshot version, which was recently developed earlier this year. We know and understand that the CSR, the Clinic Summary Report, is complicated at best, but we feel that it's better to present more data than less and allow the physician-patient relationship and in consultation review the information that is pertinent to the patient's individual circumstances. We understand that the CSR as a result is complex, so we developed this so-called Cliff Note version, so to speak, that dates back to before the CSR was changed to the more complex CSR that accommodates for all the things that we're doing, including PGT and freeze-all strategies. We encourage that all patients going back look at this data, as there is a link there where up in the upper right where the definitions of the report are outlined specifically. The reason that the CR is so complex is because our practice is so complex. We're all very familiar with this strategy, with freeze-all strategies and PGT complicating our practice, therefore making it a lot more difficult to report our outcomes. There's also a Sart Predictor tool. This is also new this year that some of you may not be familiar. It's on our sart.org website. It's not perfect, and it comes from our database from 2015. We're hoping to present the Sart Predictor tool with more recent data. But for the purposes of counseling about prognosis, it's a good tool to start with and will be improved over the next year or so. What is most exciting recently that you'll see over the next week or so, hot off the presses, is a new Sart clinic function. This is, again, Sart's mission to increase the number of patients that go to Sart member clinics. Just to reflect back is the old school way, limited options, zip state, that's it. You get this very boring list of clinics, nothing to distinguish practices. To the patient, it's not really that helpful. But we're going to have this up live on the Sart website using Google API. I actually learned what API stands for, Application Programming Interface. It's what we're familiar with when we Google search. It utilizes location, city, zip, anything that you put in. Because we all live on our phones, there's also a very nice looking mobile version. And what you'll get is a much more provocative, detailed information about your own practice that you can modify, and you can modify it on the Sart Cores platform. You'll get much more overview, success rates, linkage to your success rates. It's going to be a much better experience for your patients who are looking to see what you do. You'll get overview, you'll get a list of services that you provide, you'll get contacts, you'll get a map there to show where you are. You'll be able to build profiles, headshots if you want, specializations that you do, accreditations that your clinic has. And this can all be entered through the Sart Cores platform. So you'll get access to your marketing people to this data, and you can free text it, and you can see the slide there, the information, your address, etc. We'll announce this, and then Sart member clinics will have approximately 4 weeks to enter and adjust these new fields to their liking. You'll be able to put in your clinic services there and profiles, and your clinic specializations and any services that you provide. And you'll also be able to have specific information to satellites. So if you have a main clinic and you have these satellite clinics, you'll be able to tailor the kind of services that you'll provide at these particular satellites, including outside monitoring, etc., so that the patient will have a much clearer understanding of what the services that you provide. You can have user profiles, biotext, headshots. You can select a role if you're the IVF guru, if you're the surgical guru, you'll be able to specifically put that information in. This is all driven by the sart.org website. Obviously, you put all this information on your own website, but this is, again, trying to drive traffic to Sart member clinics. Thank you for your attention, and I will let Bill introduce Colin.
Paul, thank you very much. I really appreciate the time you put into that and the opportunity to see the breadth of activities that Sart is involved in to not only promote the activities of the society, but also to improve the quality of service delivery provided by member clinics. Our next speaker is Colin, and he is the Division Director and Chief Officer at the Columbia University Fertility Center. Colin holds a Master's of Healthcare Administration and is a board member of the Association of Reproductive Managers and the ASRM Coding Committee. Colin?
Thank you very much, Dr. Peacock and Dr. Lin and the Sart leadership team for inviting me to participate. As I have nothing to disclose, if you can't see it now, but I do have a Sart tie on, and so the first and only excuse I have to wear my coveted Sart tie has been provided by this webinar, so thank you for allowing me to dress up and wear this tie today. I was invited to participate to give an administrative perspective on what Sart can do for your practice, and I thought the best way to do that was highlight some of the resources and information that has been helpful to me in the various practices that I've worked in and helped set up, and hope that that will also provide some resources, information that could be useful to you if you haven't found them or are looking for resources or to help develop your practice and procedures within your practice. So these are sort of the 5 areas that I wanted to highlight, and we'll talk about each of these a little bit more in depth. And as Dr. Lin dove into quite a bit there, we mostly know Sart as a data reporting mechanism, a data reporting tool, so that we can all, those of us that are Sart member clinics, can easily comply or more easily comply with the regulation to report our outcomes. But it's also been useful for us and for me in reviewing and analyzing our own data sets and looking at patterns or other areas, comparing historical things and data to look at areas we might want to improve. Sart also provides in-depth patient education and advocacy for patients and for clinics to become better and provide better care and better outcomes for patients. Sart, in partnership with ASRM, is a lead advocacy team and group for federal and national laws related to reproductive rights, and some of us have seen the effects of their efforts in our state, specifically in New York. We're excited for some of the gestational laws that are starting to become more open and useful for us starting next year. As Dr. Lin mentioned, there's tools for patients to look up patient predictor kits or patient predictor information. There's the Sart mobile app that's available to patients to look up information, frequently asked questions. What is IVF? What are the risks of IVF? Generalized questions available to patients as well as providers, and also useful for us as we hire new employees, maybe a medical assistant or a front desk employee that really has no knowledge or understanding of what the IVF world is all about and what the many acronyms, IVF, Sart, ASRM, PGT, the various things we throw out in everyday conversations. In terms of regulatory review, I'll talk a little bit more about that in a couple of slides coming up, but Sart is tied in very well to a lot of the networks, conversations with insurance companies on how we as Sart member clinics or Sart member clinics can be providing better outcomes to patients, and thus in turnaround also help the greater healthcare scope of reducing costs of care in general. And Sart also provides quality assurance and certainly helps us as member clinics provide better outcomes. Sart has a voluntary consultation program where practices can get assistance or advice or help from volunteer clinicians or lab directors to ask questions, run things through. Those are always carried out in a spirit of confidentiality so that we can be collegial and help improve the outcomes and care to the patients we all provide. I also wanted to focus mostly on the administrative help, is what I call it. It's been helpful for me. So this is just a snapshot of the patient education piece that you see on their website. the patient education section on the Sart website, they've got some great infographics that have been put together, some facts and figures about IVF and outcomes, historical information. You can see on the left-hand side of the screen, they've got some micro videos that they share there, some information about IVF, third-party reproduction, questions that patients may have, and it's been a great resource and tool for us creating our frequently asked questions that we hand out to patients. More importantly for me is the member resources link on the Sart website. So if you are Sart members, you can log into the Sart website and pull up these member resources. If you're not a Sart member, when you join, you get access to these. They have a reporting, research, and a resource, some web links. And on here, you see this, again, this is just a snapshot, so I can't scroll down here, but if you scroll down, you'll see access to all those, where you can go in and find information about how to enter cycle information if you have a question about, using donor cycles or associated frozen embryos from a prior frozen cycle, etc. And really some just quick and easy links on the website. So most helpful for me, and I don't know the genesis of where these came from, but this Sart has on the resources tab there a 5 or 6 page document, Word document, that is a coding reference. And what we have done is actually taken this and handed out to all of our new hires that get put in our billing departments, so our coders, our billers, and those individuals. And it's been a great resource for them to understand what are the common CPT codes that we use in and out every day, and what are the associated diagnosis codes. And it's made their education really quite easy and accessible. For me, the embryo morphology description, this is actually something I found many years ago and just printed it out, and I actually still have it posted next to my desk. Since I'm not a lab person, it was a very common occurrence where someone would come in and start talking to me about why do the embryologists, what are these words, how are these descriptions? So I just hand them a copy of this to our new employees and say, this will help you understand exactly what they're saying and what they're referring to when they talk about what's going on with the embryos. So not specific to Sart, but Sart provides these links in partnership with ASRM to both some practice committee documents as well as some ethics committee documents. And these are extremely helpful and have been extremely helpful in guiding best practices for Sart member clinics in knowing, you can see here on the screen things to do about recurrent pregnancy loss. They've got the 5 or 6 practice committee documents that have been published this year. They go through and revise those. Similar to the practice committee documents, they've got ethic committee documents. So they answer tough questions that you probably face in your practice, and you don't have to rely on your own set of knowledge. You can pull up these documents, and odds are they have put out a document or a statement about a situation that might be challenging ethically about what to do. Errors in practice, disclosing medical errors, considerations regarding gestational carriers, compassionate transfers. There's a whole list of these ethic committees that you don't have to rely on your own best guess. You can see what has been published there. So as mentioned before, Sart has been a great advocate in working with member clinics who maybe were previously in a center of excellence with an insurance company, but then for some reason the insurance company changed their criteria, and I've been party to see clinics get put into centers of excellence or approached specifically to be in a center of excellence because they're Sart members. And Sart helps with that resource and lends a sense of credibility to know that their data is validated, that they're practicing good standing because they're a Sart member clinic, and they provide best quality of care. They've also helped set up and have the opportunity to give you resources to help set up your programs to make it easy, specifically with consent forms. And if you like or are considering setting up a donor program, they have access to some templates for that. So with the consent forms, they have both English and Spanish versions of the IVF consent process, embryo transfer process, disposition of embryos. And it's helpful to go in and use those as templates. You can sort of change the name of the practice in there, add your logo, and have a really quick and easy consent form to use for the IVF embryo transfer and disposition. Also for donor consents, and recipient consents, they have the use of a donor egg in there. And if you're setting up a donor program or need to fix or change or adjust your donor program, they have a donor screening application, a donor questionnaire, a risk assessment tool in there, and a risk factor assessment for eligibility screen of donors, links to the FDA, what the requirements are to be a donor, what testing needs to be done on the donors. Also, there's a statement there in egg donation tax information to help you explain to your donor that the IRS doesn't view this income as a gift, and it could be subject to tax. And it's a quick and easy resource to use and provide as you're consulting with potential donors about what that income might look like. These are just a few of the many resources and information pieces available to SART member clinics. As a practice administrator, you can go into SART and be listed as sort of the director of the program and pull in and use these resources and facilitate the use of these resources to improve your program and make it better. And if you have questions, certainly I'll be available at the end of this webinar to answer any questions you might have.
Colin, thank you very much. Always interesting to see how people use the SART website and the tools that SART provides in running a practice, which is an incredibly complicated situation. I'm very pleased to introduce our last presenter, Dr. Catherine Goh. She was an embryology lab director from 1984 to 2020 on the faculties of the University of Pennsylvania, Thomas Jefferson University, and the University of Massachusetts. She's currently the managing director of embryology at Tomorrow Life Sciences in New York. Dr. Goh has served on the executive council of SART and has been honored to be a speaker and chair for several postgraduate courses at ASRM in support of its mission of education. Kathy?
Thank you. I'd like to begin by thanking Dr. Peacock for the kind invitation to participate in this webinar. So I have the following disclosures, and I hope that at the end of this presentation, our listeners will be able to understand SART, which I am standing on the shoulders of Paul and Colin, who carefully described SART, define or tell you a little bit more about the Fertility Clinic Success Rate and Certification Act of 1992, but most importantly, at Bill's request, to learn how to critically read the SART Annual Clinic Specific Report, which can be a formidable array of data, and to help you identify what the parameters are, what they describe, and how they're clinically meaningful to someone who is perusing them and trying to make a decision about perhaps which clinic to attend in the hope of building a family. A little bit of history. I always think that history is important in understanding an organization and its mission. SART was founded in 1986. It was at the ASRM annual meeting in Toronto, and it was originally a special interest group on IVF. It's grown to become much more far-reaching and deep in its mission. So it is now a freestanding society within the American Society for Reproductive Medicine. At the time, it set forth the minimal criteria for membership. It developed a membership strategy so that clinics could be members and voters, as well as the medical directors and laboratory directors within the clinics. SART elects a president annually, and as Dr. Lin described, has a multidisciplinary executive council composed of different committees that carry out the work of SART. You've heard the names of some of them: the validation committee, the registration committee, the quality committee. And SART has regularly scheduled meetings throughout the year, most notably at the annual ASRM meeting. The Fertility Clinic Success Rate and Certification Act is the product of the work and concern of then Representative Ron Wyden, Democrat of Oregon, who is now a senator. But he wanted to assist patients in understanding the various presentations of data and success rates that many clinics were making, trying to make sense of them. Pregnancy rates, what does that really mean? And that is why SART adopted the all-important standard of expressing success as the only meaningful one, taking home a live-born baby. This legislation was passed in 1992. It is Public Law 102-493, and it was passed by the 102nd Congress. The point of the SART data is taken here right from the website, a direct excerpt. The SART data can give potential ART users an idea of their average chances of success per cycle. That's a treatment event, or transfer, when the patient actually has embryos or an embryo transferred into her uterus. It's very important that SART stipulates, however, that average chances don't necessarily apply to an individual or couple, The success rates will vary according to the individual patient, her treatment, what techniques they use, what her diagnosis is, the number of embryos that are transferred by the clinic, what their standards are for that, the types of procedures that may be prescribed for the patient in her treatment, such as intracytoplasmic sperm injection or pre-implantation genetic diagnosis, which has become popular in the last few years, and the patient's history of previous treatments, births, and miscarriages. Of course, the proviso that people considering ART must consult a physician to discuss their treatment options is very important for Sart to represent. So the clinic-specific report, as a body of data, of statistics, does have the intent of assisting a patient in answering that very basic question. What are my chances of having a child by IVF and the array of assisted reproductive technologies? And importantly, where can I go to get this treatment? Can I go to a clinic in my geographic region, or will I have to travel if I find that there is a clinic that has some data that seems most pertinent to my care and offers me the best chance of success? So the clinic-specific report is a body of data. It has information about all 450 plus clinics in the United States that report to Sart and the CDC. Very important. It helps the patient understand who the clinics are, who the medical directors are their laboratories accredited, and what their, for lack of a better word, performance has been, knowing that each clinic is an individual ecosystem. It sees specific types of patients. It has its own standards and policies, and it represents the philosophies of the medical director and his or her medical team, and the laboratory director and the embryologist. So it is a system that is offering care to a patient, and the patient can sort of study up on that and determine if one center fits their profile a little bit better than another. So data are collected annually, but they are released only when every outcome from every cycle that was started, every treatment that was started, has been accounted for. So that means if you're a medical director and you record and document a clinical pregnancy for a patient on December 31st of a given year, you don't expect that baby to arrive until 9 months hence, and then you can outcome that cycle, and now your database is complete and ready for submission to Sart. So every cycle must be accounted for. Dr. Lin alluded to this, and I think so did Mr. Thomas, but the data fields continuously evolve. If you look at the Sart data that's available or will be available for 2018 shortly, or the data that I show you as an example, again, in a few minutes, it will look very different from the earlier Sart reports of the late 90s and the early thousands, because the data reflect new practice paradigms. The data have to be relevant to help the patients make the best evaluations of the centers that they may want to visit. As Dr. Lin mentioned, as Mr. Thomas mentioned, the data are audited. I think about 8% of the practices may expect a visit from an audit team who will look through all of the clinical records to ensure that what was reported is what's in the patient's record. And finally, the good thing is that all of this drives transparency. You want a center to represent itself truthfully, and it also discourages commercial advertising because the data speak for themselves. So now we're going to get at it. I wanted to open by saying that I once had the husband of a friend come to me and say, help me read these tables in this Sart report because it just looks like a mumbo jumbo of numbers. And I was surprised to hear him say that, because this was a person who enjoyed perusing, just poring over the NBA player statistics, which shows, I had no idea, a dizzying array of statistics for each player. Games started, games played, minutes played, field goals, field goal attempts. And I thought, if you can read that, you can read the Sart data report, because these are all just the same things as a train schedule. You go across one column, you go to another value in the row, and where they intersect is a piece of data that's pertinent and interesting to you. Let's take a look. These are the 2017 data. So I'm showing you a sample clinic table. So this is right from the start, the way that the clinic-specific report invites you to take a look at what they're going to tell you. So you can see that, and if you look at the blue square with the 1 in it, The data are verified by typically the medical director. So these data have all been reviewed and vetted before they are submitted for publication. If you look at section 2A, these are the outcomes for all patients. They may have had previous IVF cycles in another center, or they may be starting treatment from the square one, never had an IVF cycle before. And if you look across the top, you'll see that the data are stratified by age, because the female patient age in a couple is such an important determinant of success. It is unfortunate, sad fact it is a sad fact that as a woman ages, her efficiency at getting pregnant, at delivering a live-born baby, decreases. So the data are stratified for women using their own eggs, who are less than 35 years old, 35 to 37, 38 to 40, 41 to 42, and then older than 43 and older. So the first thing is number of intended retrievals. So these are women who start a cycle by taking controlled ovarian hyperstimulation, and they are hoping to get to egg retrieval so that their eggs can be united with their partner or husband's sperm in a laboratory to create embryos. And the embryos, of course, are the opportunity to have transfer and to become pregnant. So you can see it would give the numbers of cycles that were started in each of those age groups for each clinic. And of course, the parameters of interest are what percent of those patients had a live birth. So in the sample table, we would see that 60 patients who were under 35 started treatment, and 50% of them had a live birth. The other important parameters, not only a live birth, but a singleton live birth, because that helps you identify the practices who are committed to helping the patient avoid a dangerous or risky multiple gestation, multiple pregnancy, which has medical implications not only for the mother, but also for the child or children that are born. And so it goes. Number of retrievals means that these are the patients who may have started ovarian hyperstimulation, but also succeeded in getting as far as retrieval. Some patients may not stimulate well and will have to be canceled. Some patients will take themselves out of treatment, may have to cancel for logistic reasons. But not every patient who starts ovulation induction will proceed to retrieval. And then finally, the number of patients who have retrieval and succeed in having embryos generated so that they can have embryo transfer. These may be fresh embryos, or these may be embryos that were frozen. There has been in the last few years an adoption of freezing more embryos, either for what's called freeze-all cycles, in which the physician decides that it would be better if the patient did not have fresh embryo transfer in the same cycle as her egg retrieval, because the uterus may be affected by the controlled ovarian hyperstimulation. What's gotten the embryos, what's amplified the response of the ovaries may have a negative impact on the uterine environment. So deferring transfer until an unstimulated cycle is thought to be advantageous. In addition, there has been a growing adoption of pre-implantation genetic testing of embryos that requires that after biopsy, all of the embryos be frozen, waiting or allowing time for the genetic report to be delivered, at which time the physician and the patients can review the genetic report and determine which embryo will be transferred. So whether the embryos are fresh or frozen, these are the number of transfers that would have resulted from the retrieval and the intended retrieval, of course, and give you again the live birth rate from those cycles. Category 2B helps patients who are just starting out in treatment understand the difference in the outcome between patients who may have had previous treatment elsewhere or at the same center, but these are patients who've never had IVF before. It gives a different baseline. Success rate for ART transfers among patients using eggs or embryos from a donor. There has been the introduction of frozen donor egg banks into the marketplace for patients to choose from that. Some patients are still using fresh egg donors, but this is a separate population and a separate therapeutic group that is represented in the Sart data. There are also data for frozen embryos and for data from patients who use donated embryos. Section 4 is telling you a little bit more now about the treatment paradigms, and also about what may happen in the course of treatment. I alluded to number of cycles that may be canceled before the patient gets to retrieval or to the thawing of an embryo for a transfer. These are the percentage of cycles. The next data of cycles stopped between retrieval and transfer or banking. These may unfortunately be owing to a failure of some eggs or many eggs to be fertilized, or the failure of some fertilized eggs to develop to embryos that can be transferred. There are patients who opt to do IVF or egg retrieval for fertility preservation prior to a medical intervention that will have negative repercussions on their fertility, such as chemo or radiotherapy. There are patients who will use gestational carriers, another woman to carry or have the embryo transfer and carry the resulting pregnancy to term for a patient or a couple. This is the percentage of transfers using frozen embryos that is now becoming more important, as freezing all embryos may emerge as a more popular treatment option. The percentage of transfers of an embryo that had ICSI, so this shows you the application of intracytoplasmic sperm injection in cycles. Some centers use ICSI uniformly, whether there's a male factor, sperm problem or not. They are trying to be the most aggressive in pursuing and obtaining fertilization. Others use ICSI more on an as-needed basis. And finally, pre-implantation genetic testing is usually growing the embryos to day 5. It requires a stage called a blastocyst, after which the embryo is biopsied and then frozen, after which the embryo report is interpreted and an embryo is selected for transfer. And finally, next slide, please. We have the profiles of the clinics, clinic current services and profile. So does the clinic offer donor eggs, fresh or frozen? Yes. Do they offer donor embryos? Do they do embryo freezing? Do they do egg freezing, which is one of the most recent ARTs, assisted reproductive technologies, added to the repertoire? Does the clinic treat single women? Do they offer the services of a gestational carrier? Is the clinic a Sart member? Is their laboratory accredited? Has that been verified? And then also very important for the patient to understand the array of diagnoses that is treated by the clinic. Male factor here, 28%, just an example of diagnostic conditions or services that the clinic gives attention to, and it helps patients perhaps select clinics that are more specialized or have a greater preponderance of practice in and experience in. So this is the actual data summary for all clinics in the United States who reported their data to Sart for the calendar year of 2017. So again, these are actual outcomes, and these are very useful in interpreting and understanding what the global performance rate was, global outcomes, and then you can match a given clinic against the national summary. Very important to read the report in total, though, so that you understand that if there is a clinic that treats more difficult cases, takes on more challenging patients, you have to take that into account in interpreting their outcomes against the national summary. This is just a continuation of that national summary, total number of cycles, and all of the outcomes that we discussed earlier. So hopefully by delving into the report, you can see how all of these parameters are emerging to give you a picture of a clinic, and that there is a national summary against which it can be benchmarked. I wanted to end by saying that the nice thing about the Sart CDC report is that it has the material within the report to assist the reader in understanding the data. There are sections that are entitled How to Read a Fertility Clinic Table that will be more comprehensive than what I presented just now, that they will give characteristics of the ART cycle in more detail, the reasons for using ART, and there is a glossary for understanding all of the terms. So I conclude by summarizing what Mr. Thomas and Dr. Lin also said, that this is an annually published compilation of data. It is meant to assist readers and particularly potential patients in understanding how a clinic does, who they treat, what their treatment paradigms may be, what each data point in the table means. It has descriptive information for each clinic, and all of the data are audited and validated. So it is a meaningful aid to the patient in developing their plan to be treated and to build their family. So thank you very much.
So we will now open up the floor to questions for our panelists. Dr. Peacock will moderate this session.
I want to thank all of the presenters. I just wanted to add, Colin was, he wore his Sart tie tonight, and I wore my ASRM 2002 Seattle meeting polo shirt for all of you in Seattle or who remember that far back. I wanted to add a couple of things before we get to the questions, and that is, as you know, I'm a psychologist, and how's a psychologist going to use Sart? Well, the clinic summary report, the Find a Clinic, and the patient information sections of the Sart website have been incredibly useful in my practice. Patients want to know, how does a specific clinic do with their diagnosis or their age bracket? Or they want to know, how can they reasonably understand different outcomes in different clinics. And so having those tools available and also being able to give people reasonable expectations for what to expect comes from being able to use those tools. The other thing, and I have to admit, having been involved with the website and developing some of the tools that are available in section, has been very useful. The ability to refer people to the Sart videos, which give information about things such as frozen egg use and things like that, has been useful. And I'll throw another plug in for Sart in that we've just almost wrapped up the first season of Sart Fertility Experts, which is a podcast series, and we're about to go into production for season 2 of the same series, and we're looking at season 3 now. It's been in the top 50% of podcasts downloaded and listened to. So I'd like to add that in. Now, I've got a question, and that is, it was stated that the Sart report is annually published. Why does it take so long to get the report out? And would Sart consider issuing the report twice a year instead? Paul, I'm going to turf that question to you.
Well, it comes down to what Catherine had said regarding the outcomes. It takes December 31st. It takes 9 months for gestation to be completed. And then so that's November 15th, that typically for practices to have an opportunity to even report their outcomes and track down the patient and call the patient and email the patient or whatever they have to do. We hope that practices aren't doing the bolus reporting where they're waiting to report their outcomes till the very last minute, so it's going throughout the year. And then we have to do all the processing that we talked about, the validation, the QA, all that stuff has to be vetted through, and then by that time, 4 months later, 3 months later, the report gets released in February or March of the following year. So there's a lot of behind the scenes work to make sure that the data that's being presented is of high quality. So it's very difficult to do that twice a year from an administrative standpoint. So yes, we could do it twice a year, but you could see that that is a very administrative challenge to do it on an annual basis. We're doing thousands and thousands of cycles and they need to be validated. So it would be a challenge, but certainly something that we can look at from a leadership standpoint.
There's another question that deals with the report itself. Is cycle-specific race or ethnicity recorded in the registry data? Anybody?
Anybody? Catherine, do you want to take that?
No, go ahead, Paul.
So we do ask the question. So it is being asked. Unfortunately, our traction rate on answering that question is abysmally low. So to get any meaningful data out of that is a challenge. So the report is only as good as what the data is being put in, and unfortunately, we have to rely on the clinics to report those outcomes, and it's one of our variables that has a low answer rate. The other one that's also a challenge is smoking. You know, it's quite obvious that smoking has an impact, but we are in tandem with the CDC The CDC also makes us ask those questions, and those two main questions have been attached to the CDC requirements. So as you can tell, we provide feedback to the CDC often, and we've asked for those variables like smoking to be removed, and we'll continue to ask that, but ultimately the CDC has their own agenda outside of outcomes.
Kathy, is there anything you'd add?
Yeah, that was perfect. Thank you.
Okay. So another question that comes about, and I'll give this one to Colin. If you're thinking about becoming a Sart member clinic, how complex did you find the application process?
That's a great question. The clinics I have worked with before have all been Sart member clinics before I joined their team. But I have worked with some practices that are new and starting to set up and do the Sart application, and have found it actually fairly painless to go through.
Always a good thing to hear. Let me ask Kathy, because you have been involved in laboratory work for so long, have you seen trends that have changed as a result of the impact of Sart on the practice of ART and IVF?
I think one of the most important, Bill, was advancing the concept of avoiding multiple gestations. Had a great impact on reducing multiple pregnancies, making it a safer proposition to undergo embryo transfer. The idea of single embryo transfer was a very important initiative that Sart got behind, and enforced is a strong word, but certainly it comes close to that for driving a best practice.
Thank you. I see that we have no other questions on the board right now, and I'll make a call for, oh, here we go. Is cycles, wait a second.
I can add to that last question while you look at the questions. One of the strategic plans for Sart has been communication with its members. A major strategic goal is to make aware of the Sart members and its benefits, which is one of the premises of why this webinar exists. Also, so that's the development of the portals on the Sart Core's interface, is to communicate safely and securely with our members. So that's one goal. I don't think we're there yet. I think there's a lot of work to move forward to communicate with our members. And then the other is to really build that quality branding that Sart clinics represent quality based on all the factors that Colin and Catherine have talked about in regards to holding a Sart member clinic accountable to being the best practice they can be, because in the end, it's our patients that really benefit from this kind of self-assessment and constant improvement.
We have another question. For all the Sart members to supply their data before starting the QA process and subsequently issue an annual report? And then when will the 2019 report be available? Two-parter. I think that's for you, Paul.
Yeah, so the second question I can answer, I didn't catch, you kind of broke up, but the second question, the 2019 data will not be available until March of 2021. So because, yeah, so, and that's just a function of, again, the gestation and the time that it takes. We've got it down pretty consistently to about a year and a half from when the last outcome is reported in 2019.
Yeah, and then the first part of that question is, do you wait for all the Sart members to supply their data before starting the QA process and subsequently issuing the annual report?
To answer that question, yes. Yes, there's always a few stragglers, and we try to accommodate those clinics that are late in getting their data, because we want all the data, and we also want it right? So we don't want this, so we encourage all the clinics to kind of have this ongoing and dip into the Sart course platform frequently, their data entry people, and not wait till the last minute and find this mad scramble to enter their data. And then, you know, what happens naturally is you're trying to meet data and then you cut corners. So it's very important that you have this process operationally, and we're quite happy to help Sart member clinics to create, because there are best practices. Catherine and Colin are part of these really good practices who know how to enter the data, and we're all part of the same community that can help those clinics that are struggling.
There's another question. How much of Sart data can non-members review? I'll take a stab at that and then ask anybody else to answer, follow up. You can review all of the data that's reported out by going to the Sart webpage. A summary of the last year, or you can get preceding years, and then you can get summaries by clinic. And every data point that's reported shows up on those clinic summary reports as well as the national summaries. Is that reasonably correct, Paul?
Yes, that is absolutely correct. It's meant for public consumption, so patients are not Sart members. So this is all accessible. All the aspects that Colin talked about, the benefits, Catherine talked about the CSR very eloquently. There's a public-facing part of the CSR which is accessible to everybody. That's the federal law. We have to report our outcomes. It's a very unique field. Ron Wyden was very progressive, and it's actually made our field a lot better, honestly, because who are we accountable to? The patients that we take care of, and that's the best kind of people to be accountable to.
Absolutely.
It's often been said in meetings that I've attended that of the specialty areas in medicine, Sart may be the best in terms of reporting outcome data. Other specialties do not have the same kind of requirements and quality of data. I think that's a fairly reasonable statement.
Yes.
Okay, great. Well, there are no more questions, and we have gone over our recording time. I want to thank all three of you for participating tonight and offering your expert information and guidance to those who have attended. Appreciate the opportunity to have moderated this and look forward to seeing you all sometime live.
Colin, Catherine, great job.
Thank you.
Bill,
Thank you for inviting us to participate.
Thank you, Bill. Thank you,
Yep.
Colin. Thank you, Dr. Lin.
Thank you. Take
My
care.
pleasure. Whoa, thanks to our team, Sarah and Jessica. Go right ahead, Sarah.
Thank you, Dr. Peacock. Thank you to our panelists. Thank you to our attendees. You will receive a survey by email after the session. Your feedback helps us give you the most relevant content, and your input is appreciated. This session was recorded and will be available on our website in the near future. Please watch your email for notification. For any further questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar.